about today is a project that we want to run in Leicester City. And I'm going to give some of the background, some of the top line elements of the project, and then see if we can have some discussion, if there's time, around the project and encourage sign up to it as appropriate. So I'm just going to advance the slides. Has that worked? Yes. So why? Why mouth cancer? Well, November happens to be Mouth Cancer Month, and there are some grim statistics for Leicester. So Leicester has significantly higher rates of mouth cancer than the rest of England. And worryingly, it also has the highest mortality rate for mouth cancer in England. So we have something going on within Leicester, which is producing really pretty tragic outcomes. Now, what I'm going to run through briefly today is the risk factors, the work that's already going on at population and public health level, and what we think are the major contributing risk factors. And then finally, the key opportunities for yourselves and for the health system to work together to reduce incidence and mortality from this condition. So oral cancers, we know, are rising in the UK, and this BMJ editorial highlighted firstly that mortality has increased by 15% and is going to rise. The major risk factors are the usual ones of tobacco and alcohol, but within mouth cancer, human papillomavirus, HPV, the injection that your children will have now in schools as early teenagers to prevent cervical cancer, but also helps to prevent oropharyngeal cancer. There is a socioeconomic gradient, as you'd expect, with areas of deprivation having a 50% higher death risk after 3 years. Where does it appear? Well, it appears around the mouth clearly, and I'll show you in a minute some of the major sites. But it is a disease that doesn't discriminate. And whilst I'm going to share with you some data showing that it perhaps has particular population demographics in Leicester, remember that it can appear in anyone. So when we think about mouth cancer, where do we typically see it? The lighter blue is women, the darker blue is men. So as you can see, when you look at the diagram on the left, around the tonsils, the tongue, and the base of the tongue are key areas, all of which are easily accessible on examination. On the right-hand side are the rarer head and neck cancers, and I'm not going to cover those today because the main issue is to do with mouth cancer in Leicester. So what are the modifiable risk factors? And they are the ones that you'd expect, which is smoking, smokeless tobacco, alcohol, and HPV. Now, what we know is that the key symptoms are based from the NICE guidance around teeth that become loose for no clear reason, or there's swelling of the jaw, unexplained persisting swelling and bumps in the lips or mouth or neck, and mouth ulcers that don't heal after trying the usual over-the-counter remedies. In addition, changes to do with sensation, so persisting numbness, or also white or red patches can be pre-malignant conditions, and sometimes a change in speech where it affects the architecture of the tongue. Within Leicester City, of course, we all know that we live in a super diverse city, and the last census in 2021 highlights that dramatically with a majority Asian population, but still a similar proportion with white population and the black population gradually rising as well. Now, when we look at those rates of oral cancer, we can see that when we're compared with other similar areas like Nottingham, Coventry, with similar ethnic differences, Leicester in the bright yellow still stands out as having a higher incidence and a higher mortality. And this has been sustained over many years. So the yellow arrows show where Leicester sits still at the top of the Premier League when it comes to mouth cancer, unfortunately. Now, when we zone in on where the mouth cancer are rising, what we've found is that there are particularly high areas, which include, when you look at the top of the map around Belgrave, also around Beaumont Park, but the Belgrave Rushy Meads area is the area which carries the majority of the admissions for mouth cancer. And when we look at it in more depth, if you look at the top graph, that's the rate of oral cancer admissions by age and sex overall. So you can see that men outnumber women, light blue rather than dark blue, and there's a peak between 60 and 70. But when you look at the bottom graph, that's where the problems start to show themselves. We have, in fact, twin peaks. And when you look at ethnic minority patients, predominantly Asian Indian, the yellow bars in the bottom graph show that we actually have a peak in the mid-40s in ethnic Asian patients. And in fact, we've got a tail of patients all the way down to 20 to 24. So there is something within Leicester that's different to the rest of the country. And it isn't matched by smoking, because smoking, in fact, there's more smoking in the bottom left of the city than there is in the top right, which is all the mouth cancers. And the alcohol is spread through the city. So the traditional risk factors don't apply. We also looked at dental access. And in fact, dental access is broadly poor across the whole of Leicester City. So let's build this story up and start to think about what's going on and what we can do. So with dental public health, there's been a whole strategy being developed around how do we reduce this? And the first element is, of course, improving awareness of the signs and symptoms in the population, then reducing risk factors, and then finally improving the access to medical and dental advice on symptoms, with the problem that many people can't register with an NHS dentist. And so that's why the bottom bullet point is around creating options for dental access. But when we looked at the risk factors in that Asian population, there are two things that stand out: shisha and palm. And so palm is something that's just been recently shown in a large Lancet survey as contributing around a quarter to a third of all global mouth cancers. So now we're starting to get into the story of why there is this peak at an earlier age amongst ethnic Asian patients. We also have conducted an awareness survey, and what we found is that in Leicester City, around where you can see the pink star at the bottom, in Leicester City, around a fifth of people in the general population had experienced symptoms that could be oral cancer. The next thing that we asked in that question, what did you do about it? And unfortunately, a significant number thought they'd just ride it out and leave it and didn't seek attention. When we look at the public's awareness, well, actually, the Midlands with a pink star, under half of people recognise the key symptoms that I highlighted at the beginning. So we have an issue with population awareness, so they're not sure when to attend or when something could be serious. And we have a number of resources that have been developed through public health around both self-examination, including a self-check video, but we've also been looking further, and we've looked at shisha. And one of the things, if you look at the graph on the left at the bottom, that's Rushy Meads and so on, and the Melton Road is marked with that pink arrow. Look in the middle, that pink arrow is the Melton Road again, and those are the shisha cafes, as you can see, all lined up along the road. And then if you look on the right-hand side, those are the registered or the cafes which on Google Maps sell palm. So you can see that actually there's quite a significant clustering of the known risk factor agents. So what we're doing is we also want to improve the training of health professionals, because typically we get very little time in being shown how to look at the mouth, how to examine it for cancer, and then what to do with what we're finding. And when asked, adults would seek advice about mouth symptoms either from the doctor, their dentist, some would go to A&E, but a significant proportion would actually utilise their pharmacist in order to try and treat along the journey the symptoms that they're seeking. Now, the problem with going to see a doctor, and I don't need to tell you, is that we are very difficult to get into these days. And so increasingly, because of the lack of dentists and because A&E is around, increasingly we're finding that pharmacists are becoming one of the key sources of advice. And what we wanted to do was to build on a study which looked at whether pharmacists were interested in or had knowledge about suspected head and neck cancers. And Andrew Sturrock led a research project in 2022, which actually looked into this. And this was actually in the north of England. But what they found was that there was a knowledge gap and also an opportunity with frequent consultants for mouth symptoms, or in fact, anyone who presented with mouth symptoms and had risk factors. And so our initial project was thinking about those red zones, the Belgrave, Rushmead, and that amounts to about 17 pharmacies with 10 around the edges, mixture, but many with Gujarati and Hindi-speaking staff. This has been part of a wider program working with public health, and one of the elements that we thought we could link into is the great work that's been done around extending the Pharmacy First programme and the training that was delivered within the last couple of months on examination of the mouth and ears. And we thought that we could add this training to those interested pharmacists and pharmacy teams in the form of blended training. So free face-to-face training, if that's what would suit you, online webinars and some videos. And we're going to signpost these. The plan is that if you see something and you're not sure what it is, then you signpost the patient to their GP or dentist. This will be supported by setting up a professional group for this project by email, and then the evaluation would look at the numbers of people you'd examined and what happened, whether they went to see the GP or not. So just moving on to the resources, and all these resources are going to be in the PDF that I'm going to share with you. If you just click on the resource on the slide, it'll take you to the resource. Amazing resource from Cancer Research UK, which shows you all the different aspects of how mouth cancer presents and what you can do and what the normal range is and the things you need to be concerned about. There's also an excellent resource which will build upon your existing skills of examining the mouth, 2-minute video by Richard Shaw showing you how to examine systematically. And then there are 10-minute modules on mouth cancer and head and neck cancer. So this is actually low impact. You don't need to put aside hours and hours on this kind of learning because you can learn the key things that you need very quickly. And if you wanted to practice them, that's what the face-to-face sessions could involve. For those of you that actually want to know a little bit more and want to take a bit deeper, perhaps for your own appraisals, there is an excellent free head and neck module, but it is 60 minutes long. So you need to put aside a coffee and really properly put it in as part of CPD. I'm not going to talk about that. These are the kinds of things that are the benign lesions. These are the nasties, and I've just taken these from some of the resources to show the quality of images that you see. That's all that I'm going to say. There is more I can, of course, share, but I think it would be reasonable now, given the pressure of time that we have, to actually go back and see if there are any questions from the audience or in the chat that I could answer.
Thank you so much. Feel free to raise your hand or add it in the chat. You're all very quiet this evening, but I'm sure that's just because you're digesting all the information there.
Okay. I would add that that this project is going to be funded so that pharmacies and pharmacists that take part will get a payment. It won't be enough to take you to the sunshine, I'm afraid, on such a cold day, but it will be enough to recompense you for your time taken. Virginia, Ginny.
Oh, thanks. I feel like a naughty infiltrator because I'm not really supposed to be here, but I thought that was fantastic. Thank you very much. Really interesting. Just could you just make it clarify for me what kind of feedback loop have you got with your research? What sort of endpoints and things are you looking for? So wonderful sort of educational stuff.
Yeah.
I'm hoping for increased rates in pharmacy or.
Well, the first thing is, Ginny, that no one has gone down this route for oral cancer. There are NHS England pilots around spotting cancer symptoms and referring on. This is the first time oral cancer and mouth cancer have been focused on, particularly because of Leicester. So the first thing that we want to do is to test the effectiveness of the training and to see if that is something that we can reproduce and that evaluates well in terms of its delivery and the time that it takes. Beyond that, what we want is to measure within the volunteer pharmacies the number of times that this has been undertaken. And we have, and I actually skipped through it, actually, we have a risk calculator, which will be in the slide pack that you'll see. But with the risk calculator, you can actually print off the key risk factors and your findings, print them off for the patient, or the patient can take a screenshot and take it with them to the GP. Now, in an ideal world, we would try and link those patients that go on to see GP and dentist and the eventual outcomes. Unfortunately, GDPR, over the space of 6 months of trying to get the information governance right, it's proving to be very difficult. So I think at this stage, we're limiting ourselves to showing that this intervention is feasible educationally, delivers examinations and onward signposting, and then it would end up being a bigger project beyond the pilot to actually try and link it into data sets.
Thank you. Sounds great.
And by the way, the training is open to GPs and GP trainees and physician associates.
Good.
Yeah. That's fantastic. So, Bhavan, just to recap then, if there's a pharmacy that perhaps, either is in the pilot areas that you've alluded to or actually aren't, how do they get involved? Like, what are the steps? Do they contact you?
Yes.
And do they have to meet a certain criteria, or is it anyone that wants to get involved?
I think at this stage, because whilst those areas in the northeast are the highest incidence, actually people have cars and feet. And so they will travel and they might present at any point. So at this stage, while we're piloting, I would be happy to engage with any pharmacies that were interested. My email address is on the very first slide. Very happy to be contacted by interested parties. I have spoken about this with Paul before, and the ICB is generally supportive of this initiative. I'm also hugely aware of collective action, both within general practice and within your professions. So doubly appreciative of those pharmacists that can sense the urgency and importance of this kind of project for our population.
No, that's brilliant. Bhavan, could you just add your email into the chat before you go?
I will do, of course.
And I'll just double check that there's no other questions or comments. Thank you, Paul. That's great. Any other comments or questions for Bhavan before he goes? Oh, that's wonderful. Thank you for that. And I'll make sure we circulate that in the follow-up email as well. Just want to say thank you so much. I apologise that we cut down your time in terms of we could probably dedicate a whole hour to this and probably longer as well. But I would encourage all contractors who are interested just to contact Bhavan directly via that email. So thank you ever so much for joining us, and thank you for supporting as well. If you want to, I can circulate the slides if you're happy with that, but it is recorded as well. Yeah. That would be great.
Of course. I'll send you a PDF with it all. It'll produce less of a blockage in the inbox.
That's fantastic. Thank you so much.
Thank you. Bye-bye.
Have a good evening. Bye-bye. Bye. So to follow on, I'm just going to go straight into and introduce, probably needs no introduction actually, because Dr. Ashman's made a few appearances now, but I'm going to pass over to Dr. Ashman, who's going to be talking to you about RSV tonight. So thank you so much for joining as well, Dr. Ashman. So over to you.
Thank you. Thanks very much. So I'll just share my slides if I can persuade my computer to play ball. So let me know if you can see that one.
Yeah, we can see that.
Great, thank you. So RSV, respiratory syncytial virus. So I'm here really following on from having come along and talked about measles, because we had an outbreak of measles, and then pertussis, because we had rising pertussis rates, particularly in the county. But RSV, the main reason why I'm here talking about it, I suppose, is it's come into the news more because of the introduction of the RSV vaccine, and so it's largely to sort of close that loop and explain a bit more about that that I'm here. So what is RSV? So as its name suggests, it is a virus. I'm sure you worked that one out for yourself, and it's incredibly common, and I bet you all know loads of people who have had it. But a lovely thing about it, in a way, is that it's very predictable. So we know exactly when it's going to happen, and I'll come on to that in a minute. You remember from the other slides, from the other diseases that we looked at, we talked about the R number, and the R naught of RSV is actually, it's just a little bit more infectious than COVID. So in a naive population with no immunisation, no sort of social distancing or any other measures in place, one case of RSV is likely to infect 3 other people in normal life. And then, of course, they'll go on to infect 3 more and so forth. So nowhere near as infectious as measles or pertussis, but still, a significant concern. And just like the others, coughs and sneezes through the nose and mouth and eyes as well is how it's spread. And going back to that sort of predictability, that this chart is a really nice one for just showing all of the various respiratory diseases that are so prevalent, in our community. This isn't looking at total case numbers, but this is all the swabs that have gone in and have been sampled and they've got results from. This is, which diseases did they pick up? So these are sort of positive lab tests. And if you look at the blue line first, the bright blue line, that's rhinovirus, so common cold type symptoms. And then the purpley red line is COVID. So you can see that just as we were all kicking off with campaigns for vaccinating flu and COVID, COVID and colds were really prevalent, which is probably why a lot of people cancelled their initial appointments or were slow to make appointments for their COVID jab, because a lot of people were unwell in October with those diseases. Flu, if you look to the left, you'll see that it did quite a late peak, a sort of January into February type peak last season. And this season, it's just beginning to lift up. And we have been told by the UK Health Security Agency that they're a little bit more concerned about the Midlands than they are about other areas. We seem to be lifting off a little bit more quickly than elsewhere. So watch this space. We shall see. But there in the dark blue, mainly along the bottom of the graph, is RSV. And as you can see, there's almost no RSV activity all through the year. It really does peak very strongly in December, usually just before Christmas, which is what it did last year. And so far this year, we're tracking it and it's going up at a huge rate of knots and looking like it's doing exactly the same again as expected. So in terms of symptoms, RSV, I mean, for some of us, if you're a healthy sort of younger adult or a sort of older child, as it were, you're going to just get cold symptoms from it, really. So runny nose and a cough, sore throat, feeling a bit tired and headachy, just the usual sort of thing. So there's a lot of RSV out there that doesn't go diagnosed because people aren't unwell enough to go looking for swabs or anything else. So it's very, very common in terms of symptomatology. But the symptoms are very different in the very elderly, who can become extremely unwell with respiratory sort of decompensation and requiring admission and secondary sort of pneumonias and that kind of thing. But particularly our focus is on little children, and babies under 1 year of age do really badly with this. They can get really irritable, go off their feeds, get very tired. They can suddenly just stop breathing. So a little bit like with pertussis, how the first sign in a tiny baby might just be that they stop breathing. Similarly with this, they can suddenly start pausing or reducing their breathing ability. They sometimes will get a fever as well, but not always. But children tend to get fevers more easily than adults with these things. Now, RSV accounts for around 33,500 hospital admissions in the under 5 age group here in the UK each year. So it's causing a ridiculous amount of, if you like, illness and workload and stress. But also, if you look at children up to the age of 2, about 90% of them will already have had RSV at some point in those first 2 years of their life. So again, it just shows you how ridiculously prevalent it is. But on a more somber sort of note, it's the leading cause of infant mortality in the world. And in the UK alone, we get 20 to 30 cases of deaths each year in infants. So, very serious impact. And this now focuses these statistics on just that tiny baby age group, the sort of under ones, the actual babies in arms. And the JCVI estimates that each year that population group, RSV will generate 108,000 GP consultations, 74,000 visits to A&E, 20,000 paediatric admissions, 900 intensive care unit admissions, and 22 deaths here in the UK. So you can see absolutely how worrying it is. I think a lot of people are less aware that when we talk about bronchiolitis or we talk about croup, both of which are quite common bits of terminology which people bandy around, we're usually talking about RSV. It's a really common cause of these symptoms, these sort of disease processes. And bronchiolitis is often in the younger children. It's often where RSV has got down into the tiny little airways and tubes at the base of the lungs and is causing inflammation. And they often end up with a sort of almost wet, wheezy type thing going on, where they really struggle to oxygenate themselves. Their lungs are, really inflamed and not right. And croup, often it's a slightly older child, isn't it? But with that sort of seal-like barking cough that sounds like a seal coughing or whatever. So that's a really common noise, isn't it? We often hear that in the younger generation. Very often RSV is driving that. But this picture, I think, really just sums up what we're worried about. We're worried about newborn babies, those in the first few months of life who just have absolutely no capacity to cope with what RSV can do to them. And that's why the vaccination programme has been launched predominantly. So there are two aspects of it that we would just like you to be aware of. We're very aware that people will come wandering into you asking all sorts of questions, and we think it would be really useful to us, but probably very useful for you to know what's going on with it. There are very few pharmacies in the UK that NHS England are piloting RSV vaccination in. There are a few, but not many. And as far as I'm aware, in LLR, this isn't a vaccination that's so far, at least, being delivered through pharmacy. But initially, the plan in the future is that everyone, when they hit 75, will get sent an invitation and offered an appointment to have a vaccine for RSV, and that they hope will protect them. They think at least 2 years, but they're hoping that the effect will go on for longer. No one's clear yet about whether there's any chance they'll decide there's going to need to be a booster. We kind of hope not. We hope it's a one-off thing, but we don't know for sure yet. But because, as with most of these programs, when you introduce them, you've got several cohorts of people who've just missed out, really. They've just turned 76 or 77. And the decision has been made that 5 years worth of near misses will get offered a sort of vaccine on a catch-up basis. So initially, we've got a 5-year cohort, those aged 75 to 79, anyone under the age of 80, basically last summer when it started up. And that group will be offered it right up until their 80th birthday. And those who were 79 already this summer, they've got an extra, a whole year to do it. So if they turn 80 rapidly, they've still got a few more months that they're allowed to come forward for it. But as I say, on an ongoing basis, this will be a 75th birthday offer. But more importantly, in some ways, given the little babies that we're worried about, we've also got this vaccination programme aimed at babies. Now, babies themselves don't get offered a vaccine. The way the vaccine works best is by giving it to the pregnant mum, allowing the opportunity for those antibodies that she creates to cross the placenta. Baby gets born with an automatic supply. So very much like pertussis, where we're hoping that by vaccinating mum, we give the baby the protection it needs. This isn't going to push out the scheme that already exists, whereby we give antibodies, so immunoglobulin, to very vulnerable children for RSV. So that already happens. Newborn babies who have perhaps major heart defects or major lung abnormalities, they will still be offered that. But this is for all the healthy, normal mums, pregnancies, babies, everyone else is being offered this vaccination during pregnancy. And it can be given gestationally anywhere after 28 weeks. Now, I mentioned to you earlier on that RSV is a very seasonal disease, but don't be fooled. The vaccine is not going to be remotely seasonal. So it's going to be a gestational thing for the pregnant mums, and it's an age birthday related thing for the older adults. So where can they get it? So older adults, GP surgery or our roving vaccination unit. For pregnant women, the UHL antenatal clinics at the General and the Infirmary have immunisation rooms there. And when ladies go for their 20-week FASP scan, that's when they're usually offered their pertussis vaccination. Now, ladies who have a complication in pregnancy for any reason, it's about 50% who have a pregnancy where they might need an extra scan or some extra checkups done. Those ladies will be able to wander back into those clinics later on in pregnancy when they're 28 weeks plus and get their RSV vaccine in the same space. But ladies, and as it's around 50% of them who have a completely straightforward pregnancy, will be seen by community midwives right up until the point they go into labour. So they won't have a reason other than this vaccine to go back to UHL. And because they're aware of that, what UHL plans to do is to set up immunisation clinics in some of the community hospitals scattered around LLR. Those are beginning now, but not widely advertised yet because they're just finding their feet, but we'll soon be pushing them heavily. And it'll be Melton, Market Harborough, Hinckley, Colville and Loughborough hospitals, as far as we're aware. GPs can also give the RSV to antenatal patients, and the roving healthcare unit can as well. And we've already kicked off and had a good start. I think we're up to about 80 vaccinations for pregnant ladies done on the roving healthcare unit so far. But you can see from the figures, just up to the 11th of November, already nearly 15,000 older adults are protected for this winter. But antenatally, that's well over 1,000 babies are protected against RSV when they're born this winter. This is some of the locations where the roving healthcare unit is going to be going. And in case there is someone where you would like to be able to advise them how and where they can get their vaccine, the QR code on here is invaluable because it takes you to our new web pages where there's sort of an explanation for each of the vaccines they might want, where they can get it and how they can get it. And including, for many of the, not for RSV, but for COVID and flu, for instance, lots of sort of, community pharmacy clinics as well. So it's a really useful place for them to go looking to find their vaccine. And I think that's it. So thank you very much indeed for having us and letting us tell you all about RSV.
Thank you. Just a couple of questions. Tarek's just asked, will community pharmacy get that poster? Presume was it the poster, Tarek, that you're referring to, offering the walk-in vaccination service?
Yes.
So the roving healthcare unit one with the dates on. So
Yeah.
Sam creates that. And I mean, we don't usually do it as a poster because it goes out of date quite quickly. And by the time we've circulated it across LLR, it's kind of gone out of date. But it'll be in the slide pack, so you're more than welcome to print that one off. But the QR code is probably in some ways more useful because that will take you to a place where it keeps on getting maintained all year round. So in May, a pregnant woman will be able to find out where to go and get her RSV vaccine, for instance. So, but yeah, it'll be in the slide pack.
Brilliant, thank you. Are there any questions around what Dr. Ashman's presented around RSV?
Stunned silence.
Oh, don't think you've got a question, Sam, is it?
No, I haven't. I haven't got a question. I was just going to say, on a Friday, that roving unit schedule, I do send it out to a group of people that are interested in cascading it. So I'm quite happy to add any of your members to that distribution list. I'll put my contact details in the chat. So if anybody wants to receive that roving unit schedule every Friday afternoon with all the updated locations on, I'll add you to my distribution list, and that's when you'll get it.
That'll be great, Sam. So if anybody is interested, just pop your email address in the chat function. Sam, could you also forward it on to me, and then I can just share it with all the pharmacies, whether they're on this call or not. And then we can just mail it out every Friday.
Yep. Sounds fab. Thank you.
No problem. And also the QR code as well. I know you said it will be in the slide deck, but if we can just have that as QR code, we can actually just host it on the website, to be fair, and signpost pharmacists and contractors onto that to access that. And if it's updated, if there's any changes, presume it will just be uploaded onto the QR code website. Yeah, perfect.
Yeah, and there is another QR code which maybe Sam might be kind enough to send you as well, which takes you to the front page of this it's a new website effectively. On the ICB website, we've now got a whole section which is all about vaccinations, all kinds of vaccinations. So lots of information for patients. So again, if there are any weird and wonderful questions patients have and they're not sure about what they're due or what they're eligible for, that QR code just takes you to the front page. The other QR code takes you to a more embedded page, which is the sort of vaccination finding page, but both might be useful to you. So you're very welcome. Obviously, would love you to direct people to it where appropriate.
No, that's brilliant. Happy to do that. That's fine. Dr. Ashman, no problem. Any other questions? I think Kate's just so Kate said we can obviously share those things on our social media as well for Facebook, etc. as well, and other platforms, so we can get it to the public as well as our pharmacy, community pharmacies in the region. Fabulous. Any other comments or questions for Dr. Ashman or Sam? Sam, did you want to give an update just in general about vaccinations or anything?
No,
Did you have anything around
I'm just Ginny's sidekick.
Okay.
Yeah, one other update I would just give, just in case anyone's able to do anything about it, is that we've got quite a lack of COVID jabbing going on in the city generally. I mean, I'm not pointing fingers at anyone. This is just the way it's working out. So a lot more patients coming forward for flu jabs and a lot less coming forward for COVID jabs. It's something like 22,000 COVID jabs have been done in the city, and over 60,000 flu jabs have been done in the city. And I know it's slightly different, subtly different eligibility criteria, but not massively different. So that's, we're a little bit worried at the moment that the COVID campaign looks to be slightly behind where we would hope it would be. So any final push any of you can do who are COVID vaccinating be very much appreciated. Thank you.
That's fine, no problem. And how does that compare to last year? Is it the same picture as well, or was it completely different?
So, I mean, generally, the uptake is always a worry. You know, such a small percentage of the eligible population finally get vaccinated. But with the trajectory that we're on at the moment, we think County and Rutland are going to almost hit last year's final end total. But we don't think City is. Currently, it looks like it's on a much lower trajectory, and it's going to stop a long way short of where it needs to end. Oh, thank you, Sam. That's just exactly the one I wanted. So this is obviously the COVID one, and you can see City there, 22,779 jabs given out of a possible 98,198 people who were eligible. So we're only on 23.2%. Last year, we only ended on 36.6% of eligible patients having had a jab. But we don't think, with only 4 weeks to go and Christmas to distract everybody, most of the COVID programme happens in the first few weeks, actually. So we're just a bit concerned that 23.2 is not going to hit the 36.6 that we would like it to. So yeah, just anything you can do would be very much appreciated. Have you got the flu one there, Sam, just for contrast? Thank you. Sam's, see, as if by magic, she's just amazing.
That's it. This is why she's your sidekick.
Absolutely, she's brilliant. So yeah, you can see again, so purple down the bottom is last year, green is this year, and City flu 60,421 doses, so at 29.7%. So still, there's a worry we're not going to get to the 38.8% that City got to last year, but it's they're closing the gap better than they are for COVID, as it were. Again, as usual, County and Rutland outperforming City, but again, we're hoping they're going to reach their end percentages from last year. Past experience tells us they won't, because each season we get slightly lower and lower uptake as we go on, and those percentages just shrink a little bit. But yeah, a final push would be much appreciated if there's anything you can do. Just asking that question of patients, I suppose, if you're able to, just to see if you can remind them. Thank you.
No, that's really helpful. Thank you for sharing that. Just that insight in terms of where we were last year to this year as well, and just good to see where, in terms of the eligible population, and versus those that have actually received it. Tarek, you've got a question. Do you want to just come in?
Yeah, just on the COVID side of it, are there any satellite clinics set up around the localities? Because I know some ICBs and areas have got satellite, they've got vans and other things going around as well.
Yeah, so our little roving healthcare unit has got all the vaccinations on it. So it has COVID on it and is doing lots of COVID clinics. And we particularly tend to send that vehicle to areas where we know that the local pharmacy and PCN provision is a little bit lower than it needs to be. So that vehicle is very much following its geographical nose according to that sort of, the amount of on offer, the concentration of COVID clinics available locally. So that will continue all through December, and we're hoping that will drive some traffic, foot traffic too.
Brilliant. Thank you ever
Thank
so
you.
much. Oh, sorry, Tariq, did I just cut you off? Apologies.
No, just a thank you for that.
Brilliant. Thank you. Any last questions or comments for Ginny and Sam? No? Okay. Thank you so much again, Ginny and Sam, for joining us this evening, just to give us that oversight, not just about RSV, but the vaccination status as well. Been really, really helpful. Appreciate your support for the open house surgery as well again. So thank you. And if you could share the slides, Sam, afterwards, that'd be fantastic. And we'll circulate them to our contractors for those that haven't joined or have joined and want to access them. That's brilliant. Thank you so much.
Thank you very much. Good
Thanks.
evening to you.
Thank you. Bye-bye. Bye-bye. Right, so we've got about 15 minutes. I don't have many in terms of updates to provide to you. One thing I did want to just really use this time is a couple of reminders. The first one is around the NHSE workforce survey. That's now live and it is mandated. So all community pharmacies up and down the country, including LLR, need to complete this. The expiry or the deadline is the 11th of December. It is on our website. So if you go on to Community Pharmacy Leicestershire and Rutland, it's on the home page and you can just click onto that and it will take you to the relevant resources and what you need to do in order to complete it. So 11th of December is the deadline. I'm not sure what the status is across the region yet because I've not had that data, but I suspect at some point further down the line we may get that, and so I will cajole those that potentially haven't completed the survey as well. But don't rely on my calls. Please do complete the survey way in advance, particularly before things start to pick up before Christmas, although I appreciate things are probably already picked up with the Christmas rush as well. So that was one thing. Another thing is looking ahead to 2025. We're planning a different event to support pharmacy contractors within LLR around delivery of pharmacy contraception service. So if you could just save the date, and I will make a formal announcement via email. But the date for that face-to-face event will be the 19th of January, and that will be co-hosted with our colleagues from CPPE, and that will be based at the Hilton Hotel. So that is a Sunday, so it's the 19th of January, but it's to support in terms of pharmacy contraception service. And something I said earlier on in my previous open house surgery from last month, but again in today's meeting for those of you that were on the call for the appointment booking platform, is post March 2025 as part of the PCOP, so pharmacy contraception, blood pressure check service and pharmacy first will all be mandated. So community pharmacies will need to deliver all three elements of PCOP going forward from 1st of April 2025. So this is really about getting you guys equipped and ready for those changes that will no doubt have an impact on you as well. So just save that date for your diaries. Those are the two main updates I had for you this evening. I kept it quite light because I wasn't sure how long Ginny and our colleagues were going to be, but we've for the first time we've actually got a bit of time. So I'm going to just ask, I don't know if Paul's on the call. I noticed Paul was on the call. Was he? Has he disappeared? Yeah, Paul's actually disappeared. So I just wondered if Paul had a quick update from the ICB, but I suspect not. That's fine. Gareth, do you have any updates around Pharmacy First? Sorry to put you on the spot, but I'm just thinking we've got a couple of minutes to spare. So if there is anything that you'd like to highlight, feel free to around Pharmacy First or PCOP agenda or even PCN leads as well.
Thank you, Rashri. Just to flag that some of the problems around receiving referrals associated with the multi-factor authentication, that's been a real blight in the system. And the ICB has made arrangements for Leicester HIS, that's the Health Informatics Service, to that they're mobilising an engineer to go around practices to help them install this multi-factor authentication on top of the PharmRefer system, which is for sending Pharmacy First referrals. So if you've got any practices where electronic referrals have stopped, It's probably because the system has fallen over in the surgery because of this multi-factor authentication. Do let us know, and we will be able to send you the email with all the details from Leicester Hiss, how to get that practice back up and running again with multi-factor authentication that has been installed without the glitches. You're muted, Rashri.
Sorry, I just said Tarek's got a question, so I'll just bring Tarek in, probably around MFA issues. Tarek, was that a question for Gareth?
No, I was going to just bring to your attention, you may be aware or not, but with community pharmacy, there has been some MFA issues where if the site is doing COVID vaccination and you've got pharma outcomes, if you're using the Microsoft Authenticator and you've got, say, pharma outcomes, and you try and add the MFA for the outcomes for health, it replaces pharma outcomes MFA. So you have to use Google Authenticator. There's another one. That was one of the problems I've picked up on sites over the last few weeks as well, and which we've addressed. But I spoke to Pinnacle and said there's an issue with Microsoft Authenticator replacing the code, so people are then struggling to get into pharma outcomes.
That's a very significant point. It would be good to see something in writing, Tarek, if you've got any official information that we could put on the website or circulate. We need to get our heads around that.
I'll check with my contact at Pinnacle, because I had an issue at a site where I literally had to drop everything and turn up, and we had to reset everything. And when I spoke to my contact there, that's the advice that they had given me. And if I've got anything in writing, I'll send it. If not, I'll ring them and I'll get it and I'll send it over.
Thank you, Tarek. Thanks, Gareth. Was there anything else, Gareth, you wanted to add? Not to.
No thanks. No thanks.
Brilliant.
I think all good.
No,
But people should go and do a quick item for their revalidation. Think how good you'll feel this time next year when you go to do it and you find one or two. So you could have one on RSV there, couldn't you? And
absolutely.
Oh, well, you could have two there tonight, couldn't you?
Yeah, one on oral cancer as well. Absolutely. Tarek, you've got your hands up again. Do you want to quickly come in?
Yeah, just a bit of feedback. I've just come off another meeting. I've got back-to-back meetings today, but I've had a Southwest ICB meeting where they've kind of they're going to start some collaborative work with the pharmacies and liaising in respect of pharmacy first, the targets and how to kind of engage the doctors, the BP services and contraception. And I think that might be an idea across the board. That's the second ICB meeting I've had. I've been involved in. I use the term UK because I've had one in London, one in the Southwest, and I think that will help and improve because pharmacies are struggling to hit the targets. And obviously the gateway criteria and the targets, they are difficult in certain localities, and some of the gateway criterias, you might see a patient, you can tell that they need an antibiotic, for example, or they need something, but you can't give it because of the restrictions and the eligibility and whatnot. But then they go to the GP and they issue with a prescription for an antibiotic. So I do feel that it's going to get tougher in hitting these pharmacy first targets.
Completely, yeah, I concur with that. It is getting tougher. I think it's not that it's getting tougher. It is getting tougher, and it's only going to get tougher as well. And I think who just alluded to like GP collective action as well. That's got something to do with some of the referral rates. So we are working with the ICB, just to reassure you, Tarek. We have we work closely with Paul, as well as our admin team, Gareth and Vin as well, a part of that. But we do have a wider network within the ICB. So we have our monthly steering group with the ICB looking at PCARP initiatives. So like you've just alluded to, blood pressure check service, looking at the numbers, the referral numbers, more importantly, the patterns, the trends, and what more importantly we can do around that. And that goes across for pharmacy contraception and pharmacy first as well. So we're looking at each segment or each element of that, so of PCARP in terms of the services as well. Gareth, did you want to add anything on top?
Yes, if you're speaking to practices, this was something I should have remembered earlier. The NHS and practices are tuning into winter pressures planning at the present time. Winter pressures, that's the buzzword that's been around for years. And if you have a chance to push pharmacy first, just say to them, every practice, just deflect every cough, cold, runny nose symptom, earaches, nasal congestion symptoms, just get it straight across to community pharmacy on the minor ailments referral. And don't try and dilute the message by talking about impetigo and shingles and things like, just park that, just a quick soundbite. Winter pressures, that's what's flavour of the week or the month at the present time, and just say to them, just don't even entertain a single patient inquiry about coughs, colds, runny noses, whatever. Bang them straight across to community pharmacy as a pharmacy first minor ailment. Don't even worry about triaging, because if it comes across as a minor ailment, the pharmacist will escalate it to a clinical condition as necessary. Hopefully that might help.
Tarek, do you want to come back in?
Yeah, sorry. Another point that's come to my mind is DMS, because obviously the migration between pharma outcomes and MYS is not there. The reporting system is quite poor, because I've set some samples to them. We just need to kind of re-emphasize to the pharmacists to make sure that they're entering the data from pharma outcomes onto MYS, otherwise they're going to be losing money. And I do see the reports at stage 2 and 3. If there's no contact with the patient, it could be that the stage 2 is going to happen next month. But from the reporting systems, you can't tell. So there's a potential loss of income for pharmacy as well.
That's really helpful tip. Thank you very much. Absolutely. Brilliant. So just to bring this to a close, because I think we could probably bounce off in terms of talking about PCARP for a long time. Conscious it's almost 9 o'clock. If there's no more questions or no more comments, feel free to drop off. Kate will upload the recordings and share the presentations from this evening as well, hopefully by the end of the week, if not early next week. I just want to say a huge thank you for joining us this evening and for your support. And it seems a bit early, but if we don't speak to you, we wish you a very Merry Christmas and a good new year, and we'll see you on the other side. Thank you. Just stop recording as well.